Go.
Welcome to this session dedicated to the contemporary adoption of invasive coronary physiology with microcatheter-based technology at GIM meeting. Let me start thanking the sponsor of this session, Inside LifeTech and Yukon, who made possible to get an excellent panel of experts discussing about this topic. So without further ado, I'd like to hand over the word to my co-chairman, Iginio Colaiori. Iginio, please.
Thank you. Good morning, Emanuele. The title of our symposium is Contemporary Adoption of Invasive Coronary Physiology with Microcatheter-Based Technology. We have to say that in the last 10 years, the field is rapidly evolving, moving from pressure wire physiology and need of adenosine to physiology with no need of adenosine, and more recently, to FFR derived from conventional angiography, namely QFR, or derived from coronary CT. So it seems that we made a step back with guide wire and microcatheter again. We have to say that FFR derived from conventional angiography or from CT have shown to be a promising tool. However, we have to realize the accuracy of these methods remain lower compared to invasive functional assessment. In other words, invasive physiological evaluation remain the gold standard to assess lesion significance of epicardial stenosis. As you also know, invasive functional evaluation can be done using either pressure wire or microcatheter. So you should attend this session if you want to understand the role of a microcatheter-based physiology, also through a critical appraisal of available literature. If you want to know how to correctly adopt the novel True Physio microcatheter, and finally to discuss the importance of physiological assessment to plan and optimize treatment, to assess its results, underlying the added value of microcatheter-based physiology. So let's move to the agenda. Lecture number 1 is entitled Wire-Based versus Microcatheter-Based FFR Measurement, Strength and Drawback, and it will be held by Luigi Di Serafino. Then we have a Lab in the Box, performed by Emanuele Barbato and team in Aalst. And finally, we have the lecture number 2, Microcatheter-Based FFR, to plan and optimize PCI and to assess functional results, held by Simone Biscaglia. So, without losing any time, let's give the floor to Luigi Di Serafino, which is interventional cardiology at University Hospital of Naples. So please, Luigi.
Thank you, Iginio, for your kind presentation. And thanks to the organization for this kind of invitation. So we all know what FFR is and how it has changed our current clinical practice in the field of the interventional cardiology. Basically, the FFR is the ratio between the maximum achievable blood flow in a stenotic vessel to the theoretical maximum flow in the same vessel in the hypothetical absence of any stenosis. We also know that only during maximum hyperemia, a ratio between flows can be simplified as a ratio between two pressures, namely the distal pressure, which is actually measured by the pressure wire of the pressure microcatheter, and the proximal pressure, which is actually measured by the guiding catheter. There is a large amount of evidence supporting the use of FFR in the current clinical practice. First, we know that deferring PCI of intermediate stenosis on the basis of a negative FFR value is safe, even at very long-term follow-up, as demonstrated by the DIFFER trial. In the FAME trial, the FFR-guided PCI of patients with multivessel disease is associated with a better clinical outcome as compared with the angio-guided PCI. And much more interestingly, the FFR-guided PCI of functionally significant lesions improved the outcome and better as compared with medical therapy alone. More recently, with the intention to validate the IFR, a non-hyperemic tool for the management of patients with multivessel disease, more than 4,000 patients have been included in the defined FLAIR and SWEDEHEART, confirming the role of physiology-guided revascularization procedures. For these reasons, the current European guidelines for the diagnosis and management of chronic coronary syndromes largely support the use of FFR and non-hyperemic indexes to evaluate intermediate stenosis, particularly in patients presenting with multivessel disease, unless presenting with critical, very critical stenosis. However, the penetration of the FFR and IFR, so these functional measurements in Europe, is extremely low, particularly in Italy. So why a microcatheter-based FFR? First of all, because after adenosine administration, wire manipulation is one of the reasons why FFR adoption remains underused worldwide. Although with significant improvement of materials and techniques, a pressure wire will never be comparable to a regular workhorse wire. In addition, there are some unmet clinical needs which need to be addressed, and probably the pressure wire does not facilitate this progress. These represent some differences between the true physio microcatheter as compared with the other conventional pressure wires. First of all, the microcatheter can go through a conventional and more used workhorse wire. In addition, while the pressure sensor is placed in a fixed position, mostly at 30 millimeters from the distal tip of the pressure wire, this is not the case for the microcatheter. Of course, the pressure sensor is fixed on the microcatheter, but the distance of this pressure from the distal tip is incredibly short, 2.5 millimeters. And this is important because it allows to measure not only distal lesions, but even more proximal lesions when some operators have some difficulties to go through particularly tortuous vessels. And most of them usually are used to frequently disconnect and reconnect the cable from the pressure wires. And this increases the risk of pressure wire damage and the risk, of course, of finding a significant drift at the end of the measurement. So you are obliged to perform the measurement again. These are two case examples demonstrating the cases where even the operators extremely extremely confident with the pressure wire management would rather prefer to use a regular guide wire. And honestly, the case on the right coronary artery represents a case where even performing the angiography would result in a difficult job. Another point of discussion is represented by the equalization, which is actually a simple step, but it can be sometimes even more difficult than usual, particularly when facing with difficult anatomies. For example, in case of osseal stenosis, just here represented with of the right coronary artery. In this case, we cannot go through the vessel with the pressure wire as distal as possible before the equalization. So in this case, we have to perform the equalization with the wire just a little bit placed in the proximal part or the vessel. So in this makes the system extremely unstable. So in the majority of the cases, the best solution would be to perform the equalization with both the guiding catheter and the pressure wire placed freely in the aorta, in the ascending aorta. Of course, this situation does not occur if you are using a microcatheter. In this case, you already have the pressure, the wire, the regular wire, the workhorse wire, placed as distal as possible in the along the vessel. So you can take the guiding catheter out of the ostium without any fear to lose the entire system, and then you can perform the equalization with the microcatheter in an easy way. Another point of discussion would be the pullback maneuver. Sometimes we face with serial stenosis, and in this case, in order to evaluate which one has to be treated, so the one with the largest pressure gradient, we have to perform the pullback maneuver in order to get the precise, in order to focalize our attention on the function, the more functionally significant stenosis. Just go back to the previous example. So in this case, this measurement would result in a difficult job. In fact, for two things. The first thing is that we are obliged to pull back the wire in order to get the maximum gradient along the two regions. And then in this way, we lose the access to our artery, unless we don't use a second wire as a body wire. In addition, and much more importantly, while you are performing the pullback maneuver, you have to keep great attention to pressure tracings, because sometimes the guiding catheter can be attracted by the ostium, and a pressure damping would result. This pressure damping could even mask the pressure gradient, and of course we can lose the right position of the wire, so the right position of the pressure gradient, and we can underestimate the ischemic potential of the lesions we are measuring. In addition, some operators know this problem, and they try to keep the guiding catheter outside of the ostium as long as possible, but sometimes the tension is too much, and the system can jump out. So this means that we are facing with an anatomic situation which allows to underestimate the ischemic potential of the lesions that we are measuring. This does not occur with the microcatheter. In this case, indeed, we have the wire already placed distally into the vessel, and we can just measure the functional significance of both the lesion just pulling back the microcatheter and not the wire. So you will always have the access to the vessel, and you don't have to be afraid to lose your system. Another point of discussion would be the rewiring for post-PCI assessment. This topic will be further and better presented by Simone in a few minutes. So these are both the console, the Vivocardio system, which represents the interface between us, the operators, and the pressure signals. And on the right, the true physio-rapid exchange pressure microcatheter. So this microcatheter works like a regular balloon. It can go through every regular workhorse wire. It has a really ultra thin profile with a dimension less than 1.6 French. It has been made for saving both time and contrast, particularly for complex PCI. It has been designed particularly for keep the procedure of pullback more safer, and for the assessment also for the function result in a post-PCI session. So this is the true physio microcatheter in one piece with its own cable. And here on the right, we have the distal part, which is actually a very interesting part. It has a very small profile, and the sensor area is really short, 5 millimeter, and the distance between the distal tip and the pressure sensor is really short, 2.5 millimeters. In addition, there are two markers. So the pressure sensor is located in between two radiopaque markers with 3 millimeters of distance, which allow for sensor location and, why not, the lesion length estimation. So the true physio microcatheter comes in one piece together with this cable. So we don't have to connect and disconnect the wire or microcatheter because you already crossed the lesions. You just have to measure it. This is the Supreme study, which has already been presented as late clinical trial, breaking trial a few months ago. It's a comparison between FFR assessment performed with the Abbott pressure wire and the microcatheter, the true physio microcatheter. And it has been showed a very good accuracy of these FFR values obtained by the microcatheter as compared with the pressure wire, together with a very nice, good correlation between the two values. In addition, there was no significant difference in terms of drift magnitude between the two tools. However, the rate of clinically significant drift was significantly lower with the FFR microcatheter as compared with the pressure wire-based FFR. So why a microcatheter-based FFR? In the pre-PCI evaluation, it allows to assess the ischemic potential of equivocal stenosis and to decide on the management. And it allows to use any workhorse wire, saving time, contrast, reducing drift, especially in challenging anatomy. During PCI, there is no need of changing wire since the workhorse wire is already in place, thereby it facilitates PCI procedures. In the post-PCI assessment, it allows to maintain the guide wire positioned distal in the vessel while we are functionally assessing our results. So basically, microcatheter-based coronary physiology simplifies invasive functional assessment, and it might further improve the adoption of physiology, both to indicate and to guide PCI. Thank you.
Thank you very much, Luigi, for this very nice presentation. Let me start the discussion by asking whether there are questions from the other colleagues, from Simone, from Iginio.
Yes, Emanuele, I actually have a question. So, Luigi, you made nice examples of using microcatheter in complex cases. So, can you tell us something about the performance of true physio in like calcified lesion in terms of crossing profile, pushability, and so on? Thank you very much.
Thank you, Simone. This is an interesting question. Actually, I have been, I had the opportunity to use this microcatheter a few times, and it was impressive because it seems like a regular balloon, CTO balloon, and it works really easily. It goes really smooth through the calcific vessel. But what was really impressive is the fact that you don't have to be afraid to cross with your pressure wire tortuous vessels. You already have the wire. You just have to measure, and you can reach the very distal part of the vessel in like an easy job. So it's impressive.
Luigi, do I understand well that the crossing profile of this balloon is favorable? I mean, it's not like a bulky microcatheter. Is that right?
Yes. It's a nice. It has a very low profile. It can go smoothly, and it's really impressive. I mean, it was a nice experience.
Iginio, any other question from your side? Perhaps you should open the microphone, Iginio.
Luigi, a practical question. If I have a vessel with two serial stenosis and I have to put my sensor of the conventional FFR wire more detail I can, honestly, I cannot do normally. Do you think we can overcome this issue with True Physio?
Yes, indeed. The fact that True Physio has the sensor positioned in the very distal part, just really close to the distal tip. And this allows not only to measure very distal lesions, but even allows us to measure even proximal lesion if the wire does not cross the entire vessel, because the extremity, the extreme tortuous anatomy. So it this prevents from the occurrence of spasm, and of course it simplifies our measurements.
Thank you.
Thank you very much. I think we are quite well set in terms of timing, and we can move on to the live in the box or recorded case. I will hand over now the word to Emanuele Gallinoro, who's introducing the case. Emanuele, please.
Thank you, Emanuele. I will present the case. So the case I'm going to present has been recorded in the Cardiovascular Center in Aalst, Belgium. The patient is a 72-year-old lady with diabetes, dyslipidemia, and obesity. She had recently an inferior STEMI in December 2020. The culprit lesion was located in the proximal right, as you can see from the left coronary angiogram. And on the right, you can see the final result after the implantation of a 323 stent. But this was a case of a multivessel disease. Indeed, here we see that there is a moderate stenosis in the middle AD and a mild to moderate stenosis in the distal circumflex and in the first marginal branch. So our plan was to perform a physiology guided PCI, so to evaluate the hemodynamic impact of this stenosis, and also to perform a post-PCI physiological assessment. Do you want to go on, Emanuele?
Thank you very much. And that's the way it starts, as usually. There is a calibration phase where we make the console, the VivoCardia console, speaking the same language of the MACLab console. So once the aortic pressure is calibrated, we open up the fluid fill connector and we get synchronous measurement of the aortic pressure. As we usually do after a primary PCI, this patient was taken back to the cath lab a couple of days later. We check the patency of the stent recently implanted in the culprit vessel. And as you can see, the vessel was fine. The flow was fine as well in the right coronary artery. Let me take also this opportunity to thank Katia Van Kutsemanedi, who were the nurses helping us during this recording. Now, this is the right coronary artery. You will see now the left coronary artery. The quality is a bit better as the one seen in the slides. And you can appreciate these intermediate stenosis in the mid-circumflex and in the first marginal branch. Now we move to a cranial view where you see this long lesion in the medial AD. It's actually a little bit longer if you pay attention than what we see on the angiogram. The disease starts even earlier than the first diagonal branch. Let's see in this angiogram. So the disease starts before the diagonal branch and goes way beyond the ostium of this side branch. In this specific moment, we took as a guiding catheter an EBU 6 French. We are transradial right in terms of vascular access. And this is again another projection that makes you better understanding the anatomy of this LAD lesion. There we go. Good, Iginio.
Thank you. Okay, let's do a quick round of opinion. Ferrara and then Naples. How would you manage this patient, Simone?
So for the non-culprit lesion, I would have tried to acquire a projection for an angio-based FFR reconstruction during primary PCI, and then I would have tried to perform the analysis offline after the procedure, and then if positive, took back the patient in the cath lab.
Okay, Luigi?
Yes, this is a nice case example how the things goes in the cath lab. This is interesting. I seen that your first injection was on the contralateral vessel irrespective of the STEMI. So you performed before the angio of the non-culprit vessel and then the PCI or the carpal lesion. This is how exactly perform also the primary PCI in my current clinical practice. Actually, I would have performed the FFR in the acute setting. This is what I have been. This is what I would have done in this case, because of the risk of finding, of course, non-significant lesion, and then the risk of taking back the patient on the table again a few days later.
Thank you, Luigi. So I think we can go back again to Aalst. So please, Emanuele.
Yes.
Thank you very much. What we did in this case, we took the patient back, as we said before, and we started the functional evaluation of the circumflex. What is the advantage of the true fission microcatheter? You use the guide wire you want. We used, in this case, a B&W wire that we position in the circ. We are now ready to take the microcatheter. What we do to start with, we unpack the device. We flush with saline, pure saline, the plastic hose that contains the microcatheter. And then we connect the microcatheter to the console, as you see done in this moment. There we go. On the display of the console, there will be popping up this 0 PD. All what we have to do is to push on that. And we are now ready to introduce the microcatheter within the guiding catheter. You know, it has a short monorail that you can appreciate now that I'm loading the microcatheter on the guide wire. Let's follow this step. You know, it's a very tiny microcatheter. As Luigi was alluding to before during the presentation, this is really a good profile. It's so thin that nearly mimics the tip of a guide wire. And that is why I suspect this microcatheter can really advance and slide everywhere without any kind of problems. Now you will see the guide wire coming out of the short monorail, just to give you an idea of the monorail segment length. And now we introduce the microcatheter within the guiding catheter, much like we would do with any kind of monorail balloon. You know, once we are with the tip of the microcatheter at the level of the tip of the guiding catheter, you can clearly see where the tip of the microcatheter is, because we have these two radiopaque markers and the pressure sensor is just in between these two microcatheter. It is the moment to flush the system. So what I like to do on my manifold is to take out the syringe with contrast, take a new syringe and flush the whole system in order to make sure that there is no residual of contrast within the guiding catheter that can dampen the pressure tracing. At this very moment, I perform the equalization by simply pushing on that button. The two pressure, the artery pressure and the pressure measured by the microcatheter, are perfectly superimposed. At this moment, we are ready to advance the microcatheter. All what we have to do, because we already have in mind the localization of the stenosis, we have to advance the microcatheter and induce hyperemia. Now, in our case, we use intracoronary papaverine. And you know, papaverine and contrast do not really go well along. So if you have to inject papaverine, you have to make sure that contrast is flushed away. And that's what we did from the beginning. Now we start recording and we inject the bolus of papaverine. You see, that's the advantage of combining microcatheter with papaverine, because we don't have to use again contrast when navigating the pressure wire within the coronary artery. The guide wire is there. All what we have to do is to push the microcatheter distal. This is the FFR. Yes, please.
Sorry, Emanuele, just a quick question. After papaverine, do you flush with saline or just you inject papaverine and you wait?
No, we flushed with saline. As you noticed, Simone, I injected 3 cc within the dead space of the guiding catheter. And when you saw me injecting with saline, it was just pushing forward the papaverine that was already in the dead space of the guiding catheter. So it's in a way, yes, to give you an answer. So there we go. This is the assessment of the circumflex, 0.92. At this moment, all what we have to do is to pull back the guide wire and go to the marginal branch. Now, we record the first measurement, 0.9, as we saw on the console of the microcatheter. Now, we move on. At this moment, I need contrast, and I asked to Emanuele to inject some contrast because I'm navigating the wire, repositioning it. But that is the only moment I give contrast. Once the guide wire is in place, I already know where the pressure sensor should be located in order to assess that particular lesion. So again, the 2 markers at the tip of the guiding catheter. Let's remember the sensor is located between the 2 markers. We check again the equalization. There we go. I already flushed with saline. In the interest of time, it's cut from this video. I advance the microcatheter. Okay, this is the resting PDPA. And there we go again. Papaverine in the dead space of the catheter. I ask to the nurse to push on rec. There we go. Now we are recording. I wait a few seconds to have resting PDPA recorded, 0.98, 97. Open the stopcock, inject saline, pushing forward the papaverine that is already in the dead space of the guiding catheter. And now we observe now the hyperemic response. Please notice also the time of each measurement. Less than 1 minute, actually, the first one. The second one, we pull back, we check the equalization, we check actually if the 2 pressures are going back to 1, and then we stop recording. So this was also not significant. Now, what you see here, 0.73, that's actually an error that the system does in detecting the maximum pressure gradient between the aortic pressure and the microcatheter pressure that we can correct afterward in data archiving, but I'll share this with you at the end of the session. Now, the second lesion is also non-significant. We reorient the guide wire towards the LAD. We change projection, as we all do in our daily practice, and we advance the guide wire to the LAD. Very safely, always with the same B&W wire. Cranial view, again, the microcatheter at the tip of the guiding catheter. We reconnect papaverine at the stopcock. We take another syringe with saline that we connect at the other stopcock of the manifold. That's what I'm asking to Emanuele. There we go. We make sure that the contrast that is in the guiding catheter is completely flushed away. So a couple of, you can also see that the composition of the syringe with papaverine is different, the density from the composition and the density of the saline. Now the system is ready. We check the equalization again. Eddie, our nurse, pushes on equalize, but you see it's always 1. We just do it in the interest of education. So PDPA is 1, equalization is correct. Then we advance the microcatheter into the distal LAD. I know exactly where the stenosis is, as I use the radiopaque part of the guide wire as the landing zone, if I may say so. Now we are distal. At this point, I ask to record the pressure tracings. You will see that shortly the record button will turn to rec. There we go. And now we inject papaverine in the dead space. Actually, it's at this very moment that I push on record. There we go, in order to have a clean measurement from the beginning till the end. Now we are recording. That's the resting PDPA 0.86, 0.87, 88, okay. And you saw now that the aortic pressure is just interrupted shortly because I injected papaverine, and now we see the hyperemic response. It's going down, 0.84, 83, 81, 79, and I guess the lowest value will be around 77, 78. But you see there is a significant hyperemic gradient. There we go. We stop recording, and what you see, it's a snapshot. Yeah, the lowest value is 76. You will see a snapshot that the system recognizes as maximum pressure gradient. Of course, I do the pullback also to see where most of the hyperemic gradient is located. We stop recording, equalization is more or less okay. Voila, it gives you 0.63. Again, it's the usual trick that I mentioned before, that the system detects, captured the maximum pressure gradient. That doesn't mean that is the correct FFR, but in the data archiving phase, we will demonstrate how to pick the correct pressure gradient also for future recordings. Iginio.
Perfect, thank you, Emanuele. I'm now curious to know how in Italy we induce hyperemia. So please, Luigi, which drugs do you use? And then Simone.
Well, actually, we currently use adenosine, most of the time adenosine, even adenosine IV.
IV, perfect. Simone?
Adenosine IV also. We on all the cases. Yes.
Thank you. So please, if we have some questions for Emanuele, we can start from Luigi.
Yes, Emanuele, thank you for sharing this nice example of a patient with multivessel disease and several lesions everywhere, I must say. I was wondering why you did not measure the FFR in the first diagonal branch.
That's a good point, Luigi. Actually, physiology in bifurcation lesion has been investigated, but not in the sense of truly guiding PCI of a bifurcation lesion. So in other words, if you measure FFR in the LAD and in the diagonal branch, that is not predicting what will happen in terms of functional significance to the diagonal branch all the way through the PCI. In other words, if I stand the main branch and I have a significant plaque shift towards the diagonal branch, FFR pre at baseline does not predict what will be and whether there will be a significant plaque shift. So rather than investing time in measuring FFR into the diagonal branch at the beginning, it's much more useful to do it just at the end.
Thank you.
The PCI.
Perfect. Simone?
Yes, I have a very practical question. You almost already said it, but is there any difference in terms of protocol of FFR performance with the microcatheter rather than the conventional pressure wire? Or it's the same actually?
Well, that's a very important point, Simone. We should try to always have a standardized protocol when doing invasive physiology. Always we have to be consistent, repeating always the same step. And as you saw throughout the procedure, we roughly did the same steps as we would do with the pressure wire protocol. So correct equalization, flushing the contrast out to avoid dampening of pressure, and inducing hyperemia, pulling back, checking whether there is any focal versus diffuse disease gradient, but you will discuss this later, and check always whether the two pressures, whether the equalization is correct at the end. So in a nutshell, it's exactly the same protocol as compared to a pressure wire-based physiology.
Thank you, Emanuele. Now I'm curious because in Italy, we use adeno IV. You used papaverine. So my question is, how long hyperemia lasts with papaverine? And how is the methodology to use papaverine?
That's a very important practical question, Iginio. Papaverine has the advantage of having a longer half-life as compared to adenosine. And the hyperemic response of papaverine IC is longer as compared to the hyperemic response of adenosine IC. So just to give you a magnitude of reference, with adenosine IC, the maximum hyperemic response lasts between 50 to 20 seconds. With papaverine IC, it can go up to 1 minute. What does that mean practically? It means that you can perform nice pullback curves even during the maximal hyperemic response. With adenosine intracoronarily, that's not possible, because by the time you get the maximal hyperemic response, you don't have the time to do careful pullback. And second advantage, as compared to adenosine IV, is that you don't have to wait 2 to 3 minutes to achieve a maximal hyperemic response, as it is the case in the IV infusion.
Thank you, Emanuele. Let's go for a last question for you, Simone, please.
Yes, another practical question actually, because when you perform FFR pullback, you have to go through the vessel at least twice or thrice, and then every time you're not so sure that you are in the same position as before, and that you can interpret the pullback in the same way. So do you think these can be different with the microcatheter? Is this a meaningful difference or not in your opinion?
That's a major difference between a pressure wire-based physiology and a microcatheter-based physiology. As I tried to demonstrate before during the case, you place your guide wire, your workhorse guide wire, in a certain point in the vessel, and you have the radiopaque tip of the guide wire as a reference. You know that depending on the guide wire, it's 2 to 3 centimeters long, this radiopaque tip. So if you decide that your starting point of the radiopaque part of the tip is your landing zone, then you can be consistent that landing zone will remain the same all the way through the assessment in the case. With pressure wire, how we do it currently, and you are experts, so you know better than I do, you have always to check with contrast. You take an angiographic landmark, a side branch, a diagonal or septal branch, you position the pressure sensor there, and you keep in mind that it has always to be there. So each time you go in and out with your pressure wire, you have to give repetitive bolus of contrast. That's a major difference between the two systems.
Thank you, Emanuele. Luigi, do you have a last question for Emanuele?
Yes, thank you, Iginio. Well, it was impressive how the drift was always less than 3 units in all your measurements. Do you think this might be related to the fact that you don't have to manipulate too much a pressure wire, but just to have to push the microcatheter forward? What do you think?
That's certainly one of the reasons, Luigi. What I would also add to this one is that the system is more stable and clean. With that, what I mean, contrast, the presence of contrast on the pressure sensor itself is one of the reasons for drift. The fact that the system is cleaned with saline from the beginning of the recording till the end of the pullback makes you taking out one of the possible factors to drift. In addition to the technology, of course, that this MEMS technology that the microcatheter has make the signal very stable, I must say. I never happened to really see a major drift, honestly, with this device.
Thank you, Emanuele. I think it's time to go to Aalst again to see the procedure.
Yes, here we go. Okay, so basically then for the PCI, we place 2 wires, 2 BMW, one in the LAD, and the second one in the first diagonal branch. Then we used a semi-compliant balloon, a 2.5-15 for the predilation of the lesion. The balloon was inflated up to 10 atmospheres in order to achieve a good lesion preparation. And then the stent was advanced quite easily through the lesion. The stent is a 2.75, 33 millimeters. We placed it carefully in order not to leave any residual plaque at the proximal or at the distal edge of the stent. So we placed it carefully under fluoroscopy. And then the stent was deployed and the balloon was inflated up to 14 atmospheres. Then we retrieved the balloon of the stent, and we performed a proximal optimization of the stent expansion with a non-compliant balloon at 312, also in order to facilitate afterwards the wire exchange. So this non-compliant balloon was inflated up to 14 atmospheres. Then this is the result. Then we performed the wire exchange. So basically the wire from the LAD was retrieved. The tip was kept in the stent, and we crossed the stent struts in order to place this wire in the diagonal. And here we go. And then now we have the wire that was previously placed in the first diagonal that of course is jailed. So then we pull back the jailed wire from the first diagonal carefully, because we always have this movement that the guiding catheter tends to go deep in the coronary artery, and then we place this wire in the distal LAD. So after the wire exchange, we perform the kissing with the semi-compliant balloon 315 placed in the LAD, and the 215 placed in the first diagonal branch in order to better open the struts of the stent towards the first diagonal branch. And then, of course, we finish with the final pot with the non-compliant balloon 312. Also in this case, we used the stent beads in order to place properly the balloon. And you can see from the stent beads how the struts of the stent towards the first diagonal branch are well open. Then we inflated the balloon up to 18 atmosphere for the final pot. So basically we performed the pot, kiss, pot strategy. And here you can also see again the final result with the stent beads. And here we see clearly the struts of the stent in the diagonal branch. So
thank you.
Okay.
Thank you, Emanuele, for the case. Now I'm curious to know, with my colleague in Italy, what are your attitude to do post PCI FFR? Simone, please.
Yes, I must be very, very honest. In this case, maybe I would have done on the LAD, but surely not on the diagonal branch. Because I mean, it would have been not so easy to cross with the FFR wire in the diagonal. And so I think this is the way I would have managed it.
Thank you. Luigi?
Yes, I have to say the same as Simone already told us. Probably I would have measured just the LAD and I would have performed the pullback in order to see what is the impact of the stent of the entire functional assessment of the vessel. And I would have never measured the diagonal branch after the kissing and after the pot.
Thank you, Luigi. So let's move to have some question for Emanuele. Simone, can you jump in?
Yes, absolutely. What it surprises me is, how feasible the system is. So if I think to do the same with the conventional pressure wire, I have to disconnect and reconnect and clean with the gauze and then remove the contrast from the bottom part of the wire, and then the connection is not always working, and I lose time, contrast, X-ray. So what is your feeling about this difference in this case and in your experience with the system?
Indeed, Simone, this system introduces a significant degree of simplification in our invasive functional assessment. And simplification goes exactly for the steps you just highlighted. The simple fact that you don't have to connect and disconnect in case you would use the pressure wire also to perform PCI, but some other operators might also inquire by saying, you know, I use pressure wire only to assess and not to treat, depending on the complexity of the lesion, that is already a major step forward. So the microcatheter is always connected to the console. So all you have to do is to keep it clean on the table and introducing it back the time you need it. And that, of course, contributes to the quality of the signal and to the lack of final drift that was alluded by Luigi before.
Thank you, Emanuele. Very clear. Luigi, do you have any comment?
Yes. Well, the way you, Emanuele, performed the crisscross of the wires is impressive. And probably if you would have used a pressure wire for the PCI or the main branch, you probably would have never crossed the stent struts through the diagonal branch, and you probably would have asked for a third wire. So this system probably allow us to spare not only contrast and time, but even material.
That's very well said, Luigi. We know the quality of the pressure wire has improved. Nowadays, they are really slippery, they are hydrophilic, and they can easily be handled, but it's never the same quality of a workhorse guide wire. This we know it very well. I would never dare, for example, to jail a pressure wire behind the stent struts, especially if you are in a calcified lesion setting. You never know. These are two separate bodies of the wire, of the technology, so they can easily disconnect. And that is what you avoid by using this system. You can forget whatever wire you're using. You can just use your PCI wire, and then afterward do your assessment by going in and out with the microcatheter. In addition, having good quality wire also allows you to be within the vessel without the fear to go subintimally. You know, when a guide wire is not well performing in a side branch that has been treated with kissing balloon, you never know whether there is a little intimal tear in which you can fall if the wire is not freely moving. And this system avoids this potential risk.
Thank you, Emanuele. I think it's time to see the final part of the case. So please.
Yes.
Emanuele.
Yes, here we go with the final part.
Thank you.
So
we did,
please, Emanuele.
Thank you, Emanuele. We did post-PCI evaluation. Again, microcatheter at the tip of the guiding catheter. We check the equalization. It's 1 at this moment. Always consistently, same protocol. We advance the microcatheter up to the landing zone we've given us in the beginning of the physiologic assessment. We close the stopcock, we close the valve of the guiding catheter. We see again the two pressures are up. This is now the resting PDPA. There we go. We flush the system with saline. We start recording. Few seconds to record the resting PDPA. At a certain point, you will notice that the aortic pressure interrupts. We inject adenosine. There we go. And we get the hyperemic response in the vessel. So this is the first information. FFR post is 0.93, so way above ischemic threshold of 0.8. And at this moment, we do the pullback that gives you a second information, how much I can improve this post-PCI FFR. Is there any residual focal gradient that I can treat with an additional stent? And what this pullback tells us, we stop the recording in a short while, what this pullback tells us is that there is diffuse residual disease. So there is no way I can improve this residual grading by additional stenting. And last information, the measurement was correct because the final PDPA was 1. Now you see we are going without any problem to a diagonal branch, and it took us no time to get into the diagonal branch without any effort. And at this moment, again, we flush the system, we induce hyperemia, we ask our nurse to push on REC. There we go. We are ready. We inject the hyperemic stimulus inside. and we wait for the hyperemic response. So towards the diagonal branch, the FFR was 0.90. Again, we do the pullback, and we see again this diffuse gradient all the way through with a good equalization at the end. We stop recording, and what you saw again, it's this artifactual number that I'll explain you in a while how to correct it. Final angiographic acquisition here. I would say good angiographic result, good functional result, 0.93 in the LAD, 0.9 something in the diagonal branch. We are finished. Now it comes a very important moment, data archiving. This was one of these artifactual measurements. Why? Because the system takes the measurement where the simple volume is located. So all what you have to do is to place the simple volume at the stable hyperemic response, push on the FFR, recalculate, relocate the FFR, and that gives you the right value. In addition, if you want to revisit the measurement later on, days after, you need to recall what you did. So tell the system whether you measure the LAD, the circumflex, the marginal branch. So there is some legends in the system. Tell the system whether it was pre-PCI, post-PCI, whether you used adenosine, papaverine, because this information will be useful later on. And at the end, you can review all your measurements, 4, 5, 6 measurements. You see how many we did. And each of them did not last more than 1 minute. So we did a multivessel disease functional assessment. I think we can stop sharing the screen. We did a multivessel disease functional assessment without any further waste of time. In total, 1 minute each. So in 5, 6 minutes, you have pre and post PCI assessment and evaluation.
Thank you, Emanuele. Really impressive. Impressive about the time that you see on the screen and how much is user-friendly this device. I give the words to my colleague, Luigi. Do you have any question for Emanuele?
Yes, thank you, Iginio. Well, I've noticed that the passage of the true physio microcatheter was extremely smooth even across the diagonal branch after kissing and the pot. Can you give us some feedback about this peculiarity? And in addition, what do you think the potential role? What about the potential role of this microcatheter for the assessment of coronary bifurcation, especially for the left main, where the new mantra seems to be the decay crash?
You know, left main is a different kind of bifurcation where you would like to achieve a nearly perfect result. But that is a kind of assessment that I would do honestly with intravascular imaging in left main rather than functional assessment. Nevertheless, if we are talking about stenting technique, crushing technique or mini crush implies different layer of metal that are pushed on one side of the vessel, as we know. And these layers of metal are not always easy to cross and recross, especially if we want to do final kissing balloon. But nevertheless, it is extremely important to assess the final functional result. Why? Because if we decide to do mini crush technique, you have certainly few millimeters of the side branch that are diseased as well. So it's not like in this specific case that we just showed, that we opened the stent struts towards the side branch, but there was not much of disease in the side branch itself. But when it comes to true bifurcation lesion, where both the main branch and the side branch are diseased, having a technique that enables you easily to go in and out the main branch and in and out the side branch to assess the final stenting result from a functional point of view is certainly an added value.
Thank you, Emanuele. Simone, do you have any question for Emanuele?
Yeah, so basically this was almost a live procedure and it took 20 minutes. So, and you perform, if I'm not wrong, 5 functional assessments. So I think that this is quite astonishing for me to perform such a good functional evaluation in a short time. I don't know if you can comment a little bit on this.
Simone, that is actually what a novel technology should do, should make things simpler and should also make them quicker. Just guess for a minute if we would have done this procedure with a pressure wire. Can you imagine to cross and recross a stented segment? You know how many times it's difficult because the tip of the guide wire hits against the stent struts. So we have to pull it back, talk a bit, advance, hoping that we would not enter the vessel wall, because this occurred as well. So we did this not only in the main branch, that was rather a straight segment, but we did this also into the side branch with really no extra time and no extra effort.
Thank you, thank you, thank you, Emanuele. Can I ask you? You know that our job is to restore the epicardial function, no, conductance of the vessel. You did FFR pullback, but now how do you say that the FFR that you achieve is correct?
Well, I don't want to preempt the nice lecture that Simone is going to give after this bit of the session. But you know, the higher the post-PCI FFR value, the better. Huh? It's a paradigm, but it's not always achievable. I think what is important is to check whether we can further improve post-PCI functional result. How? Checking whether there is any intra-stent residual gradient, and Simone will tell about this, and checking whether there is any focal residual gradient beyond the stents or upstream to the stent that I can further improve it by implanting additional stent. Having said that, we have to be very practical. Try to improve what can be improved, but always keeping in mind that the longer the stented segment, the worse the clinical outcome for the patient. So we should also try to avoid to have a full metal jacket at the end of the procedure. There has to be common sense.
Thank you. Very clear. Luigi, do you have any last question for Emanuele?
Yes, not because I'm addicted to the side branches, but actually, I just want to know, in case you measure the side branch, which value would you like to reach, or do you rather prefer to take care about the angiographic result and that's it?
You know, let's again be very practical, and I don't have clinical data to support this statement. But what I'd like to see from a functional result in a side branch is that the FFR value would not be lower than the FFR value that I measure post-PCI in the main branch. Because if that is the case, we are in trouble. Let's not forget that the side branch has upstream the main vessel. So what I expect a post-PCI FFR in a side branch is to tell me the impact of the arteriosclerotic burden that is upstream to the side branch in the final FFR measurement. If that is the case, I'm happy with that.
Thank you, Emanuele. I think it's time. Please, Emanuele.
Thank you very much. I think it's time now to introduce the last lecture of our session. Without further delay, I'd like to give the word to Simone, please.
Yeah, thank you very much, Emanuele. So basically, what we have to deal with in the next 10 to 15 minutes is how a microcatheter-based FFR can help us in planning, optimizing PCI, and also in assessing functional results, as we have just seen in the beautiful case presented by Emanuele. So these are my conflicts of interest. And I will try to, to touch two main issues. The first one is if with a FFR, we can actually understand not only if a vessel has to be treated or not, but also which is the underlying mechanism of the disease. So if we are in front of a focal disease or a diffuse disease or a combination of both type of disease. And this is very important because it can help us in both indication to the procedure and in planning it. And the second point will be about post-PCI assessment. So with how can we manage to understand if we are facing focal or diffuse disease with FFR? Actually, we have to use the pullback, as Emanuele shown just a couple of minutes ago. So if you have a clear cut with a big drop, as you can see in the left panel, obviously you're in front of a focal disease. If you have not clearly one drop, but just a regular curve with the same angulation in all during the pullback, you're in front of diffuse disease. And this, I think, is the first very important message about FFR pullback. The second message is it possible to quantify focal versus diffuse disease? Because yes, you can do it, but probably in real practice, you can be in trouble sometimes in understanding whether the disease you're facing is focal or diffuse. And the answer is yes, we are starting to do it. This is the PPG, which is exactly a quantitative measurement of focal versus diffuse disease. And briefly, what PPG index tells you is that if it's close to 1, you are in front of a clearly focal disease, as you can see in the left panel, where you have a beautiful focal lesion with a clear drop in the FFR pullback, while on the other panel, so the right one, you see that the PPG is much closer to 0 than to 1, which is 0.48. So you are in front of a diffuse disease. So it's unlikely that with the PCI you will improve the functional results in this patient as you would do with the focal disease. Another interesting study that has been published recently is the validation of the automated algorithm of instantaneous fractional flow reserve gradient per unit of time, which is similar. And so if you have a major FFR gradient, which is in the study more than 0.035, then you are in front of a focal disease. Otherwise, if you have a small gradient, so less than 0.015, you are in front of a minor FFR gradient, which is unlikely to be improved by PCI. And this system was validated both with automatic, but also with manual non-systematic pullback. So probably it will be helpful in the future. And as in this case, you see the angio and how you define this vessel. Is it focal? Is it diffuse? Are these serial lesions? I don't know. We can discuss about it. But if you perform this kind of objective evaluation, so both FFR pullback and this automatic algorithm, what you see is actually that you have a focal disease in the proximal portion, which is not the one maybe that is more obvious with the angiography. So, and what they found in this study is that if you have a major gradient, your physiological result would be better. If you have a minor gradient, your physiological result after PCI would be worse. So once we have some kind understood the difference between focal and diffuse disease, I think that we should discuss the post-PCI assessment with FFR and with functional tools in our practice. So I will start with the case that occurred us in Ferrara last month. So basically, this is a 77-year-old male with a non-STEMI who received PCI on culprit lesion, which was the LAD, and then it was randomized in the FIRE trial to complete revascularization. And so we, as I told you before, we already performed the QFR procedure in the primary PCI, and the angio-based FFR was positive. So we perform a stage procedure 3 or 4 days after the acute event. And then you can see a beautiful lesion in the distal RCA. And what we did was to implant a stent, and then we did our final angio. And okay, we are done. The procedure is finished, then the patient comes back to the cardiology ward. In most of my procedures at least. But what we did in this case was to perform a post-PCI functional assessment, in this case with the RFR, and not only that, but also a pullback. And what you see from the right panel, so from the functional assessment, is that you have a clear drop in the RFR in the distal portion of the vessel. But this is not apparent with the angiography. So what we did was to perform a clear stent evaluation of the stent implanted in the distal RCA. And as you can see from the black arrow, you have a clear underexpansion of the stent, which was not obvious with angiography. And it would have been easy, at least for me, to miss it without functional assessment. So, and this was exactly in the place where we had the pullback with the functional assessment. So what we did was actually to better post-dilate the stent and to perform a real final angio, and again, to perform final functional assessment. What we achieved was a good functional result with a RFR near to 1, with a good increase in FFR 0.09, and with the final FFR similar to the one obtained by Emanuele in his case, so 0.93, which is actually good without any other drop in the pullback. So I think I can have made my case about the importance of post-PCI FFR, but or functional assessment. But what I have to acknowledge is that sometimes we know with functional assessment post-PCI that something is wrong, but we don't know what to do with it. And there can be several reasons for a suboptimal physiological result. And I think that the most important thing is to understand which is the reason underlying suboptimal functional results. So there can be stent-related issues, which can be related to underexpansion, edge dissection, and so on. There can be an angiographic unnoticed lesion, especially in case of serial lesion. It can be diffuse disease. You can have also, especially with the normal pressure wire, coronary spasm, altered vasomotor tone despite nitro, or pseudostenosis. So basically what you do with the pullback is try to understand which is the underlying mechanism. These are beautiful examples kindly given to me by Damien Collison, the PI of the Target FFR trial. And basically you see that you can see that I put the stent in the stented segment, and in the upper case, what you have is an instant gradient of 0.10, and then you have a clear distal lesion with a pressure drop, which is around 0.05. So basically, you have a combination of fact about underlying the suboptimal FFR result in this case. So what you probably should do is to post-dilate the stent and then decide whether to add another stent, small short stent distally. On the bottom part of the slide, you can see a case of diffuse disease, because what you have is a constant gradient across the vessel. So you have a distal gradient of 0.06, and then you have an instant gradient of 0.06, and then you have a proximal gradient of 0.06. So yes, you can probably post-dilate the stent, but I don't think that you will achieve much of a good result going with another stent proximally and distally, because the disease of the patient in this case is much more diffuse than focal. So I don't know if this is a patient in which we can achieve a good result. Another interesting aspect, and I think we can discuss afterward with how microcatheter can be helpful in this case, is that these are two measurements of the same patient, one before PCI and the other after PCI. So basically what you see in the before PCI assessment, you see two drops, one proximal and one distal. And what the operator decided to do was to stent the proximal one, and then to perform again FFR after PCI. And then you see a new focal drop, which was in correspondence with the second one we have seen in the first measurement, which is much higher than before. And this can happen with FFR, but imagine how easy it is to tackle this with the microcatheter rather than with the pressure wire. And I think that this is the last point I want to touch with my presentation, but I think this is the most important one, which is, if we want to apply physiology to plan, to optimize, and to assess the results of our PCI, we have to do on we have to do in all the cases, because it's much a matter of applying it systematically that enables us to understand to understand the mechanism and to apply the proper measurement. This is what was done in this beautiful study by Agarwal, and what they found is that they found ischemic range in 20% of the cases, and this is what happens in all the studies about post-FFR assessment, and that they were able to do something in 96% of the cases. Again, this is a beautiful study by our friend Barry Uretsky, and what they found is that they tried to use pressure wire as a workhorse wire, but as we already said, it's not a workhorse wire, but they were able to do it and to perform a functional guided procedure from the beginning to the very end in 92% of the cases. But again, what they did was to apply it in all cases, all day, every case. And this enables you with experience and so on to achieve good results. What was done actually in the target FFR trial, and what you see is that if you are able to optimize your procedure with FFR, actually the percentage of patients with an ischemic FFR after your procedures is significantly reduced. And again, you see 1 out of 3 patients come out of our lab, cath lab with an ischemic FFR after our procedure. And I think this is something we have to deal with if we want to do a good job. So I think that I can sum up my slides in this one. So I think that physiology should become our final angiographic projection in 2021. But what we have to deal with is it possible or not to do it? Because it's always beautiful to say it, to, you know, show beautiful cases in gym and in other congresses, but it's possible when I do my cases in the cath lab. And so I think that this is actually where the microcatheter can help us, because as we all know, to perform FFR during and after PCI comes at a price. That is, as we said, duration of the procedure, contrast dose, fluoroscopy, adenosine dosage, adenosine duration, and so on. So actually, we have some barriers explaining the low use of FFR post-PCI, and they are both cultural and practical. The cultural ones are randomized clinical trials are not conclusive to this regard, and we have not clear-cut instruction in terms of number of cutoffs on what to do. At the same time, I think that the most important barrier is practical, and as we already said, is related to adenosine administration, to the impossibility to maintain wire position during pullback, to the fact that interpreting a manual FFR pullback once per month can be difficult, and also that you have to face that you're not always able to achieve the results you had in mind in the first place. And what I think is that really a microcatheter-based physiology can help us. First, because I think that randomized clinical trials are not conclusive, also because it's not so easy to do them with conventional physiology tools, whereas with a really practical physiology tool as a microcatheter, it could be possible to have clinical data in complex settings. Again, you have real almost 100% feasibility with this wire, whereas with the FFR or QFR and so on, especially in complex cases, you're not able to perform the analysis in 20 or 30% of the cases. There's no need of contrast, of more contrast, X-ray, additional time. And then you have your wiring position, you're in a safe setting, and probably as Emanuele already said, I think that it could be interesting also to, you know, to perform a combo between papaverine and a microcatheter. So I think it can really help us also in post-PCI assessment. Thank you very much for your attention.
Thank you very much, Simone. Very well done. Let me open the discussion on this presentation, asking whether there are questions also from your side. Emanuele, do you have questions?
Yes. Yes, I have a question. First, thank you for your presentation, Simone. And my question is, so we understood that with the FFR pullback, we are able to see in which case we have a focal disease and when we have a diffuse disease. But now my question is, when you have a patient with an FFR less than 0.8 with a diffuse disease, how do you behave? How do you decide whether to address this patient to revascularization, either medical, either percutaneously or surgical, or to medical therapy?
Yeah, that's $1 million question, actually. So basically what I do in my practice is that obviously if the patient has can be, referred to surgery because of the type of lesion he has or she has, the presence of diabetes and so on, yes, surgery can be an option, but actually you have no data about it. So I don't know if it's better than PCI. What I do in my real clinical practice is try to address the proximal portion of the vessel, and then if you have a diffuse disease in the distal portion of the vessel, there's not much you can do about it. So I try to avoid, as Emanuele said before, a full metal jacket, but probably I try to address at least the proximal issue.
Thank you. Thank you, Emanuele. Any other question, Iginio, before we close this session?
Thank you. If possible, I would like to ask to Simone. We understood that post-PCI FFR pullback has to be part of our functional assessment as final control angio. But practically, how do you perform pullback in your cath lab? And when you consider a focal pressure drop in the stent worthy of PCI optimization?
Yeah, another very good question. So basically what we do, we perform manual pullback. We try to achieve a standardized, let's say, speed, so 5-6 millimeters per second, so that we can, and we use bookmarks. So basically when you are in the place you think you see the lesion is, you place a bookmark so that it's easier then to understand what's happening. And as for the numbers, I don't know. I mean, there are no validated thresholds. What we do is that what actually was done in the target FFR trial. So if you have a drop more than 0.05, maybe you can think of doing something about it. Otherwise, you can leave it like that. But there's no randomized clinical database in my practice, actually.
Thank you again, Simone. Let me just check with Luigi whether he has any final remaining question before we close this interesting symposium. Luigi, are you happy? Do you have any final comment?
No, Emanuele, I'm really happy with this these presentations and this nice case example. It was I think a very nice session, clear session, and it allows us to understand not only the importance of to have the right tool for the right disease, but it also turn on the lights on new perspectives for research and for in order to achieve the best optimal treatment for our patients.
Thank you. I think with your words, Luigi, we are ready to close this session, and I will share just a few slides that summarize what we just discussed and few points of consensus on our session on contemporary adoption of invasive coronary physiology with microcatheter-based technology. These are the consensus points I feel we reached during this session. That management of patients with coronary artery disease based on coronary physiology assessment improves clinical outcome. We have now plenty of data supporting this statement, as highlighted by both Luigi and Simone. Invasive functional assessment remains the most accurate asset available to interventional cardiologists. We learned from Simone that even with novel modalities like QFR, for example, there is some issue in terms of feasibility in 100% of patients, because there are some settings where we still have problems to do that. And with non-invasive technique, we know that diagnostic accuracy is not 100%, it's not the ones we achieve with invasive functional assessment. And finally, systematic widespread adoption advocates robust simplification in the tools and techniques that we use. That is a must if we want that this technique is applied every day in our cath labs and in every setting. So there should be no reason not to do it anymore. And these are my conclusions. Microcatheter-based coronary physiology simplifies invasive functional assessment, even in the most challenging angiographic setting and post-PCI. And it might further improve adoption, both to indicate and guide percutaneous revascularization. With this, I think I stop sharing my screen. I'd like to thank everyone to have followed this session. I hope you enjoyed as much as we did during this hour or so. I would like to thank my colleagues, Iginio, my co-chairman, Luigi, Simone, and Emanuele, speakers and co-operators during the case, the team in Aalst, and of course, a special thank to our sponsor who made this session possible. Again, Insight, LifeTech, and Yukon. Thank you very much. A good continuation of the GYM meeting. Thank you.